Can every fibroid be removed laparoscopically? Today we will explore case selection in laparoscopic myomectomy. Hello everyone and welcome back to the channel. I am Dr. Riam. On this channel we simplify the minimal invasive gynecologic surgery into practical learning. Today we are discussing an important paper by Dr. Sanjam about selecting the right case for laparoscopic myomectomy. Why this topic matters? One of the biggest mistakes in laparoscopy is believing that one approach fits all. But in reality, successful laparoscopy depends on patient selection in terms of the number of fibroids, the size of fibroids, surgeon experience, operative complexities. And this study demonstrates that clearly through two different cases. Let's start with the first case. The first case, 22-year-old woman with multiple fibroids and uterus enlarged up to approximately 32 weeks. MRI demonstrated multiple heterogeneous masses occupying the abdominopelvic region, with the largest one measuring nearly 10 cm in the posterior myometrium, and the endometrial cavity was significantly compressed. Because the number of fibroids exceeded 5 and the big size uterus, the surgical team decided that the open myomectomy would provide safe access and better control. A midline infraumbilical incision was performed, vasopressin was injected to minimize blood loss, and careful retroperitoneal dissection was used to identify port ureter. From multiple uterine incisions, surgeons removed 75 myomas. The outcomes: 1 liter of blood loss, more than 2-hour operative time, patient received 2 units of blood postoperatively, and patient recovered well and later conceived successfully. So, what can we learn from this case? Extremely large uterus with numerous fibroid and multiple uterine incisions significantly increase the operative difficulty. In these situations, the theoretical benefits of laparoscopy may become limited. Now let's compare that with the second patient. The second patient was 28-year-old nulliparous with uterus approximately 12-week size. MRI revealed single intramural fibroid in the posterior wall measuring 7 cm. This patient underwent laparoscopic myomectomy. Vasopressin was injected, horizontal uterine incision created. The fibroid was annihilated, then myoma bed was repaired with barbed suture. The outcome regarding the operative time was 70 minutes, blood loss 80 milli, recovery smooth, and the patient later conceived successfully. So what does the literature say, and where should draw the line between the open and laparoscopic myomectomy? According to the literatures, surgeons recommend laparoscopic myomectomy for single fibroid up to 15 cm or up to 3 fibroids smaller than 5 cm. However, some experts emphasize that the decision should also depend on surgeon experience, suturing skills, operative time, available resources. So today we learned that successful laparoscopic myomectomy is not only about surgical skill, it is about proper patient selection. The right case can maximize the benefits of laparoscopy, while the wrong case can increase complications and operative difficulty. If you found this video useful, don't forget to like, subscribe, and share it with those interested. Also comment below what are your criteria for choosing between laparoscopic and open myomectomy. Thank you for watching, and I will see you in the next surgical breakdown. Bye bye.